Hello, everyone. Welcome to the e-training session 4, CTO-PCI. I'm Paul Gao from Taipei, and together with me, Dr. Toshiya Muramatsu will be moderating this session. We are happy to have Dr. Scott Harding, Dr. Okamura, Dr. Hsien-Li, Eugene Wu as the panelist, for the session. So we are going to have 3 presentations and then at the end, an overall panel discussion with Q&As. Okay, so let me introduce our first speaker, Dr. Lee from Seoul, from Asan. The topic is safety on Ostial CTO. Dr. Lee, please.
Thank you, Dr. Kao. During the next 12 minutes, I would like to talk about the safety issues and some related data regarding intervention for stumpless Ostial CTO. This issue is not a new one, but the safety considerations during PCI for Ostial CTO cannot be overemphasized and could be of value to talk about because it will be pretty much important, particularly for the beginners or intermediate operators. I have nothing to disclose. It is definite that there are particular angiographic features that indicate or predict the technical feasibility or success of CTO-PCI. These anatomical features has already been incorporated to the CTO algorithms and are important factors to be considered when selecting a strategy for a given CTO case. Among these, a stumpless CTO and a CTO at the point of a relatively large side branch is an unfavorable angiographic anatomy that we frequently face in practice. The problem is that these two factors are not independent. They always exist together. These cases will be the typical examples of the category of the so-called stumpless CTO with a big side branch. Just intuitively looking at these angios, the operator will agonize about the puncture point and most likely use adjunctive modalities to find out the entry cap or look for the retrograde collaterals. But because of the inherent technical features of CTO-PCI, the probability of side branch injury or occlusion and inflow vessel injury should be an important consideration in these subsets of CTOs. The most important lesion subset will be the Ostial CTO, of which the side branch would be the circ, and the inflow vessel would be the left main. Recently, we had a chance to look at the real-world data regarding the Ostial CTO-PCI. And I would like to introduce the safety issues that were detected in our study. The study was conducted by CTO operators in 13 cardiac centers in Korea. Each participating center had at least one CTO expert. Ostial CTO in our study was defined as a CTO lesion, the proximal cap of which was confined within 1 millimeter from the carina of the distal left main bifurcation. A relatively strict criterion of 1 millimeter, rather than the conventional 3 or 5 millimeter criterion, was selected by the consensus of the researchers to ignore more anatomically troublesome Ostial CTO subset we face in clinical practice. So our study includes CTO with and without stump. A total of 270 patients were enrolled. In our cohort, stumpless ostium was identified in 43.3% of patients. The average CTO length was around 21 millimeter. Left main disease, defined by more than 50% of diameter stenosis on angio, was present in 12% of patients. Of note, more than 1 out of 4 operators used either IVLS or CT angio to guide their procedure. This flow sheet shows the detailed procedure sequence of the cohort. The overall technical success was 85.9%. There were 3 cases of in-hospital death, 3 cases of cardiac tamponade requiring intervention, and 5 cases of in-hospital redo, PCI, or bypass surgery. So the overall numbers here are in line with the results of other CTO registries. I would like to focus on the clinically relevant complication that occurred during the procedure. In this study, we have obtained cases that had major intimal tears or hematomas or acute closures that occurred at the left main, around the bifurcation, and also circ. It's important to appreciate that 5.2% of these cases are not minor complications that just appeared on angio, but were apparent complications that required rescue or additional procedures at left main circ during the PCI. Importantly, we found that the apparent dissections or complications were identified during different time points of the procedure, such as after antegrade wiring attempts, retrograde wiring, or after ballooning. And this observation emphasized the operator's cautiousness during the entire course of PCI for osteal LAD CTO. This would be the typical example of left main injury when dealing with stumpless ostial LAD CTO. The operator identified the cap by IVUS and CT and tried to puncture it, but was quite hard because of the calcification. He used a stiff wire, but lumen compressing dissection occurred at the left main shaft. You can appreciate that the circ and RI is protected by a guide wire from the beginning. In this case, the operator did the reverse cart, but at the location including the stumpless ostium and left main, and this big dissection subsequently extended to the distal left main, requiring rescue procedure. Overall, there were a higher tendency for these complications in patients with left main disease or stumpless entry than in those without. The presence of both anatomic factors seem to have an additive impact on the instance of iatrogenic dissection. So coming back to what we can do, if we simply apply the expanded hybrid CTO algorithm to this CTO subset, following the arrows to the right side for ambiguous proximal cap, we may have these options for stumpless ostial LAD CTO too. However, base or scratch and go tech should be avoided. We must stick to the true-to-true strategy. The problem is that it is not always easy to stick in to the TTT strategy. In stumpless ostial LAD CTO, it's often difficult to enter to the correct point from either an intergrade or a retrograde approach. The left main is short and large. You will have less backup, and the angle of attack is large, precluding the delicate microcatheter and guide wire control. Sometimes there is heavy calcification at the entry, plaque at the left main, and the guide wire can go to the intraplaque or subintimal route. From the retrograde aspect, LAD-OS is quite far from the RCA, and we frequently fail to introduce the retrograde microcatheter toward the ostium, and you have to use a stiff guide wire with less microcatheter support. And the guide wire can go either to left main or circ according to the angle of left main and LAD. This is a side-by-side comparison of stumpless mid-LAD and ostial LAD CTO. You can easily appreciate the different features of each components and understand the difficulty to access to the right point and right direction of the CTO entry. I want to emphasize that you should always confirm that the guide wire course is truly the true-to-true course. This is a case of which the operator succeeded to wire with the integrated wire escalation tech. After precise ostial stenting, unfortunately, the circ was gone. So what happened? There was a short subintimal course of the guide wire around the carina, and after the stenting, the flap extended proximally, and you can identify the intima flap at the bifurcation with the circ on the OCT. In this case, because integrated wiring was not possible, the operator performed the retrograde direct wiring. However, you can appreciate that the guide wire location is outside the contrast field lumen. And by IVUS, you can see that the intraplaque course of the guide wire So the operator relocated the guide wire guided by the IVUS again, but the circ may have been gone if he had stented with the first guide wire. With all these technical challenges and safety concerns in mind, several recommendations can be made when dealing with a Stumpless Ostial LAD CTO. To stick to the true TTT course, we should use every information and modalities we have to identify the precise location of the stump and course of the vessel. To overcome the large angle of attack or slippery CTO in entry, we may have to make sensible selection and use of our gears, starting from the access to the guide wires. Move the CAPTEC would not be an option to be considered, and we should have to have a habit to identify the appropriate course of the guide wire around the carina by intravascular imaging every time before stenting. In the retrograde approach, we have to perform reverse cart at the point far from the LAD entry. We should avoid direct retrograde wiring toward the left main coronary artery whenever possible. But if you have to do that, perform direct retrograde wiring with extreme caution and confirm guide wire tip by real-time IVUS. Whenever dissection membrane is detected within the coronary lumen around the POC, strongly consider an elective two-stent strategy due to the unpredictable nature of the dissection membrane after crossover stenting. Of course, the dominant side branch should be protected with a guide wire during the entire course of the procedure. This is a typical example of what we can do for a safe procedure dealing with the Stumpless Ostial LAD CTO. So you can appreciate the distal left main disease and the ostial circ disease by the angio at the caudal view. By IVUS and CT angio guided guidance, the operator tried to puncture the entry cap, but he failed the antegrade wiring because of dense calcification at the CTO cap. The problem was that the RCA was anomalous, had an anomalous origin. So the operator used the JR catheter and used the extended catheter to support the retrograde wiring. Because he had some problem with the microcatheter advancements toward the septal branch, he did a balloon and dilate the septal branch and then advance the microcatheter toward the LAD. But the problem was that this was the farthest point that the microcatheter could be advanced. And you can appreciate a severe angulation at the proximal LAD and at the ostium LAD toward the left main. So there are two 90-degree angulation at the around the left main. So because he had less microcatheter support, he had to use the stiff wire to direct puncture the proximal cap. Of course, he already tried to do the antegrade wiring with the guidance of this retrograde wire, but it was not possible. So we can appreciate that the guide wires are already protected in the RI and circ, and during the direct wiring, the real-time IVUS is used to guide the retrograde wiring. But the problem was that because of the angle and less microcatheter support, the stiff wire subsequently passed through the subintimal space at the circ. So the operator had limited option in this stage. So what can he do? Because there was a distal left main and a severe stenosis at the ostium of circ by IVUS, he stented the left main circ and then did the pot. So this procedure was justified because there was a severe stenosis at ostium of circ by IVUS. So after doing this stenting, the retrograde wire was could be done wiring could be done toward the left main with ensuring the safety at this point. He subsequently did the balloon anchoring to introduce the microcatheter and then externalize the wire and did the stenting with reverse crush. This is the final angio. So this would be my take-home message for Stumpless Ostial LED CTO. Clinically relevant problems can occur around the left main at a non-negligible rate. Higher incidence of these complications can occur when accompanied by left main disease. We have to try to stick to the true TTT strategy by using all the modalities we have. And of course, we have to focus on a safe success. Thank you very much.
Yeah, thank you, Dr. Lee, for a nice presentation. We will save all the comments and the discussions at the end. So let me introduce our second presenter today, Dr. Nasu. His topic would be Multivessel CTO, the tips and troubleshooting. Dr. Nasu, please.
Okay, thank you very much, Dr. Kao. So, but this topic is a little bit very specific. So, because when we meet the double or triple CTO, we usually recommend the patient to receive the CABG in daily practice. So I checked some manuscript, but this is the data from the Euro. But usually the manuscript regarding the CTO interventions. So number of the disease vessel is described. So this paper is from the Japanese CTO expert registry. Also, we published in we described the data of the number of the vessel, but we didn't describe the number of the CTO region, or number of the CTO vessels. So in daily practice, as I said, patient with a double or triple CTO usually have a good candidate for the CABG. And of course, those kind of the patients has some risk for the PCI usually. So the safer intervention strategy, including the CABG, is always recommended. So in the daily practice, the opportunity for recognition of the double CTO is limited. So, as you know, this is not the double CTO, but the one case of the risk of the PCI for donor artery. This case has RC CTO with LED geotopardized region. So I dilated by balloon, but after balloon dilatation, the slow flow has been occurred. So even though this CTO has good collateral channel from the circumflex as a epicardial, but the patient has a severe chest pain and we meet a cardiac shock. So we checked our PCI database in Toyohashi. So I didn't check the CAG database because epidemiological examination is not needed for this session. So I checked only the CTO-PCI database. So in these 10 years, we experienced 1,500 CTO, and more than one. Oh, that means that double CTO is only 40 cases. So we excluded the branch CTO or the one triple CTO cases. So the combination of the CTO is 20% of the cases and the LAD and the RCA, the 15% of cases LAD and circumflex, and the 65% of the RCA and circumflex. The collateral channel is most of the cases. Those double CTO has the independent of the multi source of the collateral channel. So that's why maybe we can do the CTO-PCI for this kind of the complex patients. So JCTO score, I checked the JCTO score. So the first PCI is almost of the first PCI is the JCT score is very less. Now, and also I checked the procedure. In the first attempt, almost of the cases, the antegrade we recognized. So some cases I use retrograde, but mainly we use the antegrade approach for the first CTO interventions. So I showed the several cases. This case is the LED and RC CTO. Maybe I think that this is the typical indication in the daily practice for the WCTO patients. So this case, as RC JCT score 2 and LED JCT score 0, the very short region. So this is a RCA. RCA supplied some collateral to the LED. So that's why I started from the LED intervention first. So after failure of the single wire, the parallel wire worked well. They recognized the LED. This is final round 0 after stenting. And the other day, we do the RC intervention. So of course, I started from the integrated approach. And after single wire technique, we also use the parallel wire technique, recognized. So this case is not so, each CTO region is not so complex. That's why we can recognize as those kind of the cases. But however, a little bit more difficult cases we also experienced. This case is the last year's TCTP live demo case for me. So this case also the double CTO, but the RCA is the JT score 1 and the LED is JCTO score 2. So, but the LED is a first attempt that has been failed, so that maybe we need to the little bit approach for recognition with the LED. So that's why I recognize RCA first. This is a simultaneous RCA injection. So some branches supplied the ipsilateral collateral for the distal. So started from of course, it's a single wire technique, and then the second wire can be closed. The first wire can get the very small branch, and then I use this wire as a landmark. Anyway, if integrated wire can be crossed to the every branch. And then after small balloon dilatation for the RCA, all of the CTO segment, I checked the chip injection for the retrograde approach for the LED CTO intervention. So this connection is not so bad. So SO3 fortunately could pass this channel to the LED distal. And then integrated preparation, I used the UV3 and the caliber and the reverse cut and the cross region. So this is the final shot of the LED. And after complete LED intervention, I put the stent RCA also, and this is the final shot of the right coronary artery. This case is a circumflex, and the RCA CTO case is a little bit difficult. So LED is okay, but the stented, but there's no stent restenosis. But you can see the main coil is here. So the first attempted for the circumflex intervention has been failed in the other hospital. So still, a circumflex CTO region is very long. But the collaterals come from the LED mainly. So, and the RCA is also occluded. This is the areocranial view. So there you can see that some good collateral channel from the LED to the right coronary. But light is very long and very calcified CTOs. So maybe safety issue, maybe we need to the retrograde approach for this RCA region. So that's why I used I did the circumflex intervention first. So I need the IBUS guided wiring. But finally, the conquest could be passed to the distal, and they put the stent. This is the final shot of the LED. Of course, so I stated the PCI for the right coronary artery. This is a simultaneous shot. Still, you can see the very long CTO region, the distal of the RCA. So after integrated preparation, this is a chip injection from the retrograde. So this from now is a case is very procedure is very simple. Use the reverse card, and this is the final shot of the RCA. So maybe our experience of the PCI for WCTO is very limited in daily practice because almost of the WCTO cases we recommended to receive the CABG usually. Now, of course, the safer way is better to avoid the critical complication. So in our experience, I think the indication of the PCI for the WCTO is that if we meet the JCT score 0 or 1 in the one vessel, that we can treat the WCTO cases. And also collateral channel morphology is very important. So if the collateral channel jeopardized, then we should consider the CABG. But if the collateral channel is multiple or the ipsilateral or the independent, then we can consider the PCI for this kind of the WCTO cases. Thank you for your attention.
Thank you very much, Dr. Nasu, for your nice presentation.
Thank you very much.
Thank you.
Okay, just on, we move on to the last speaker of the campus, and the title is the Strategy of the CTO-PCI in the Post-CABG patient. Please.
Thank you very much, Dr. Muramatsu. It's a great honor for me to share my experience about strategies of CTO-PCI and post-CABG patients. So those are my disclosures. So the prevalence of CTO in CTO-PCI patients actually, once the patient gets an angiography after CABG, it's about 45%, right? So over more than 50%. And so there, once the patient got symptomatic after CABG, you may have a very likelihood that you find a graft failure and the patient may have a CTO. So in more than half of the cases. So there's a trend towards a higher mortality and MACE rate after CABG in patients with CTO. So those are data from our institution. And what you can see here actually is that there is a trend towards a higher all-cause mortality, but also to a higher MACE rate in patients post-CABG in comparison to non-CABG patients with a CTO. So once you do a revascularization. So what we know is that the procedural success with CTO-PCI reduce all-cause mortality and MACE significantly after CABG. So you can see here that once we have a procedural success in post-CABG, we can reduce mortality on long-term outcome. So now going to the procedural details of post-CABG CTO. So first of all, we have to do a peri-procedural planning because those patients are the most complex actually we have. So we have to try to get all the angiograms ever done in the patient and analyze them. So if possible, you have to try to analyze all the angiograms before and after CABG and use the coronary CT if the anatomy is not clear to you. Another important thing is I think we should do a really good ischemia testing before to better understand the area of interest for revascularization. Sometimes there are more areas actually post-CABG where we have collateralized arteries and we don't know actually where is the scar, where is the ischemia. So once we go for, especially for a retrograde approach over lemma, we should use the left radial approach to be able to shorten the guide, especially also for the angio when we see retrograde feeling to the RCA or circ over septal or epicardial collaterals. And I think in the complex post-CABG cases, I think we should go for a proctor or do the case together with somebody in a referral center with the patient. So now I will go to the special anatomical subsets and scenarios. So the first thing, what we often have is the anatomical ambiguity of the proximal cap, but also of the vessel. So therefore, I think we should always be flexible to change our strategy. For example, I show you here a case where you see well, there is a lemma graft, there is also a circ, and the circ is the area of interest. And I thought it's a rather very short CTO. There was ischemia in the lateral wall. And I thought the CTO might be rather short in this area. It's calcified for sure. And I could pass with the guide wire, but finally 1.5 burr could not cross. I had to step down to 1.25 burr and then rotoblade with a 1.5 burr. So after rotablating, I thought the job is done, but actually then I saw there is not the flow which I saw actually retrogradely because there is a second occlusion which to the distal branches. So therefore, I think we have to be flexible. In this scenario, I used a left radial and a shortened guide, and I had to do a super selective injection over the Lima graft to understand the distal cap. Actually, I was not able to puncture towards this cap with a Gaia 3. Therefore, I had to use the retrograde approach, and I could wire this channel with SUO 03, and finally did a reverse card tip in and rotablated and could open the channel. So could open the artery. You see, there are three important, very important channels. So I thought it's only a very small occlusion, but at the end, we had to go antegrade, rotablate the proximal cap, and also then go retrograde. So therefore, I think so the teaching point here is I think we should prepare our antegrade cap prior to the retrograde approach if possible. Makes things easier. And second is always be flexible to change your strategy. And I think a shortened guide is very useful for retrograde approach with Lima of the left radial. So now a case with no or narrow landing zone. But severe ischemia. So here you see an ostial occlusion of the RCA, and well, you see probably some septal branches coming from the RCA, but here you see also a vein graft to the circ with epicardial collaterals to the distal RCA, to the posterolateral branch, and also to the PDA. So here the question is actually a huge area of ischemia, how to proceed. So those are risky channels, very tiny risky channels. Therefore, we should think about alternative approaches. And when I turned the guide a little bit in another direction, I could really analyze this proximal right marginal branch, which gives us septal connections to the PDA. And therefore, this can be also useful in this case with an ipsilateral approach to get the wire, a retrograde approach for this CTO. Here you see the wire in the in the PDA actually, and it's very important to do a super selective injection to understand better the distal anatomy, because here you see it's a very, very, very diffuse distal anatomy, and you have to try to preserve all those branches. So finally, after puncturing retrograde, a second guide was placed, puncturing antegrade. I could make a reverse card and a guideline-assisted reverse card. And here then, as you can see, what we have to do here in this area was to use a dual lumen microcatheter. It was very important to get the posterolateral branch with filter XTR also wired. And finally, we achieved a very nice result with a long stent length. We had to place a cover stent in the here in this area where there was a small perforation here, but and we immediately placed the cover stent. So this is a post-angio. After some 12 months, you can see the vessel is still nicely open and with a relatively good result. So the teaching point is, I think we should analyze all collaterals options. We should also think about ipsilateral collateral, especially in post-CABG patient. Imagine you may have only the last remaining Lima, which is open to the LID, and the rest is occluded. And those are cases where ipsilateral collaterals can be very helpful. And you have to understand the distal landing zone. Therefore, super selective distal injection is very important. So what about the complex distal cap anatomy? And there are cases with very complex distal cap anatomy. I can show you here actually a case also regarding the following strategy. It's again a long occlusion of the RCA, and you see that the vessels are really narrowed, but this patient has severe angina and severe ischemia reaction. So here it's very easy to go retrograde actually. You see those are straightforward collateral channels there. And I was also able to go retrograde, but then I lost my I didn't know what is going on at the distal cap. So I tried to wire antegradally, but the wire went in some right marginal branch. And therefore I did a deep injection in the distal RCA. And what I could see here was very interesting, because this is the graft anastomosis. And here I show you the image. First of all, this is the old graft. This is the posterolateral branch, and this is the PDA. And here you see that there is a true occlusion, and here actually it's a jump graft from the PDA to the posterolateral. So therefore, first of all, I had to open this, and afterwards also to reconstruct the whole bifurcation here, which means I was able to do a reverse cart here, open the PDA, went again retrograde to open the this area of interest here, second occlusion, so double retrograde, and did a culotte there, and finally could open the RCA. So, which means here actually the point is be aware of potential jump grafts at the distal anastomosis. So the most common problem in post-CABG CTO is the insertion of the graft, and I will show you why actually. Here you can see also an RCA occlusion, and you see again that there is some diffuse disease on the distal RCA bifurcation. So with now wire technologies like this, you can wire it very nicely, but it's not actually the interest of the talk. But it was a suicide-free. Again, you see a retrograde dual injection from the guide and also from the microcatheter. Then I punctured retrogradely, and now my retrograde wire went in different spaces. So therefore I tried to prepare antegrade cap, and after the antegrade wiring, I couldn't get the connection of the two wires. So therefore on a certain point, I said, okay, I have to knuckle down to understand better the anatomy. And here with a rotational angiography, I could understand that my retrograde wire was already outside of the vessel, so it was going into the graft. And this is a very common problem, that your retrograde wire might end up in the graft. So therefore, sometimes in completely ambiguity, an antegrade short knuckle may help you to understand the anatomy. Then it was easy because I had to puncture, not very easy, but I had to puncture against the retrograde wire, and could do a reverse cart, finally a tip in, and had to reconstruct the bifurcation with a dual lumen microcatheter and a Gaia third, and finally could end the case with a beautiful result. So what we learned from this case is, first of all, rotational fluoroscopy might be very helpful to better understand the vessel roots, and the use of knuckle wires can help really in cases of vessel ambiguity. So sometimes we need a dual retrograde approach for post-CABG CTO, especially in bifurcation. Here you see instant re-occlusion. I did the case in another hospital, and finally, before doing the kissing, the tube crashed, and I came back 3 months later, and what I saw was a re-occlusion of the whole artery. So I had to go again and do the whole work again. You see there are feelings coming from retrograde, from the lemma to the PDA, and also from the vein graft to the circ over collaterals to the posterolateral branch. So very complex scenario. So I could go retrograde over the lemma graft and with a left radial approach, and get here a super selective injection. And then I had to penetrate antegrade cap, but the antegrade cap I could wire through the stents, and finally end up at the distal landing zone. And then I had to go retrograde over the vein graft and epicardial collateral as well. And finally, my retrograde wire over the vein graft ended up in the graft. So here I had also some anatomical issue. So I had to understand that this wire is going to the graft, and I had to redirect my wire towards my knuckle wire. And after having here a retrograde knuckle wire and antegrade knuckle wire and the retrograde wire very, very close together, I was able to do and dip in. So the antegrade Gaia third was placed into the retrograde microcatheter. So at the end, we could achieve a very nice result, but a very complex procedure with double retrograde approach. So in some of those cases, it's important to use triple access and simultaneous dual retrograde, so whenever it's necessary. So coming back to the last case, which I will show you, and so it's a case actually which is a light in the box case. Sorry.
Which was the course of the original.
So here
okay, well, this is the double injection. You see the lemma, which is not so easy to engage. And
so here you see also a very, very difficult, let's say, scenario with a vein graft to the diagonal branch and also a double occlusion on the distal RCA. And here you can see again a dual deep injection to understand the distal anastomosis, the distal bifurcation. And here antegrade cap was prepared. In front of the antegrade cap, a knuckle was done to get access to the distal landing, to the distal cap. And then with a CP12, and I did a reverse cart here, and was able to puncture inside the distal RCA, and then the guideliner was placed, and finally I could open the posterolateral branch. But the posterolateral branch is only the half of the CTO here because the bifurcation was occluded. So here you can see the posterolateral branch, and then I changed my retrograde access to the lemma. And finally, over the lemma diagonal, there were a bifurcation, there were collaterals, retrograde collaterals over epicardials, and I could do a reverse cart distally here because antegrade wire was in subintimal space and could engage again into the guideliner, did a second externalization and tip in. And finally, here you have to retrieve your lemma guide, very important when you're externalized, and then finally achieve the nice result with reconstructing the bifurcation. Distally, there was a dissection, but it was covered by stent, and it was only, so this dissection, I thought it will heal regarding that I was true on retrograde approach. And this is the 12-month follow-up. So I was true that the retrograde dissection healed completely. So to summarize this, sorry to summarize this case, I think you have to try to reconstruct all the side branches, even if sequential retrograde accesses is necessary for better long-term outcome. So to summarize, I think post-CABG CTOs are the most complex CTO scenarios we can imagine. The problems we face on are anatomical ambiguity of the cap and often of the root of the CTO vessel, and the graft anastomosis, which can change the vessel route. So we have often very fibrotic and calcified tissue, and we have often very narrow landing zone and small vessel disease, including the bifurcations. I think image modalities like CTA may be very useful, but still I have to say that we are not so experienced like in Asia. So lower success rate, we have definitely lower success rate in this kind of cases and higher complication rates. And I think the complex post-CABG CTOs should be done with very routine CTO operators or in referral CTO centers. Thank you.
Thank you, Dr. Kambis. So now we open the free discussion about the three typical complex CTO cases. First one is ostium. The second one is a double CTO. Third one is a post-CABG patient CTO. So now I started discuss with the ostium program. Ostium program is the first one is how to find it in the entry point, and the second one is sometimes quite difficult to done the reverse cut because of the ostium. So these two issues is a very important point of the ostium CTO. So some discuss.
I think it's the most difficult point is the puncture of the antegrade, puncture from the ostial. So we should check that, of course, if possible, that we always check the IVAS, and also coaxiality of the guiding caster and the backup force is very important. Now, in some specific cases, we sometimes need to the DLC, the one wire inside the high lateral branch of the circumflex, and then the second wire we can try to penetrate the orifice of the LLE. Usually the left main is a very big space there, so the puncture penetration efficiency of the guide wire is very less in this kind of situation. So that's why it is very difficult. So that maybe the guiding selection, guiding shape is also very important.
Right. So analyzing our data, we found out that almost all relevant complications occurred in cases where the ostium was very calcified and hard to puncture integratedly. So this issue actually is not one, you're all the experts, and we are all aware of these kind of complications, but actually we were very surprised that more than 5% of complication occurred then in the real world CTO-PCI, even in experts. So I think what is important is that to educate and give some our experience to the beginners or intermediate operators what can happen in this kind of complication, in this kind of CTO subset.
So
I think you
that's
have
why
to separate the removal of ambiguity and the crossing strategy. So very often you can use a retrograde wire to come very near to the proximal cap in the Ostial AD. But I see in your case, as soon as you get there, you try retrograde crossing with IVUS guide. But the retrograde is only a removal of proximal cap ambiguity. So usually I would advise people, after you get your retrograde up near towards the cap, you now have much clearer view of where the antigrade wire should go. So you should try again your antigrade.
Right.
Because the first time you try, you only have IVUS to remove the proximal cap ambiguity, and IVUS is not a perfect modality. So when you come retrograde near, usually I would like to try again antigrade to see if I can get in, because the retrograde crossing as a modality is dangerous, but the retrograde removal of ambiguity is not that dangerous. So that's the point.
Yeah, the retrograde wire is always a good marker for antigrade, especially useful in this CTO subset.
And also, I think that the IVUS, the pullback IVUS is very important. So irregular is just put the IVUS or the IVUS marking. But the pullback IVUS, like a Boston, can be seen almost real timely. So that's why I recommended that I use the pullback IVUS. Real time guided wiring is very important.
Sometimes even in CT, NGO, or IVUS, you know, if it has a dense caching, we cannot appreciate the exact location. That's some kind of difficulty we have in practice. Not always the IVUS is useful. So in that case, retrograde wire, will be more important for a marker.
Sometimes it is difficult to do the reverse cut for, especially for the LD ostium, because of wire going to the subintimal space to the left main sometimes. Mm-hmm. So what should I do at that moment?
Well, I would like to recommend just try to advance the anterograde wire as far as possible to not to balloon at the ostium, if possible. I think if you opt to do it, I would rather recommend you to do the IVUS that the proximal portion is in the exact location you expected. So even if you use all the modalities, you have to do the reverse cut at the ostium point in some cases. So in that case, you have to be very careful for that complication. If you know the potential complication, that doesn't matter. You you protect the side branch, and just if you're aware of it, it's usually okay for the experts. But everything happens when you are not aware of it. That's important, I think.
Maybe plasma wire can resolve this kind of the issue. So maybe we need to more 3 years. We need the 3 for launching.
Would it be available? I heard it about 5 years ago, but still we cannot use it. You know?
But maybe the 2023 or beginning of the 2024, maybe we can launch the plasma system.
Okay.
We will have a new tool.
Yeah, I think so.
Regarding the post-bypass CTO, I think the situation before the bypass is also very important. If you have a CTO before the bypass, then the proximal cap is already very hard. And once it's bypassed, the distal cap is exposed to systemic blood pressure again. So for those CTO, it would be extremely difficult. But most of the post-bypass CTO, sometimes it's not CTO to begin with. So once the bypass was done, the proximal vessels start to be thrombosed and then closed down. But usually the proximal cap is softer and easier to be punctured. So Kambis, do you agree? I mean, the situation before the bypass also affect the result of that intervention?
Absolutely, because when you have a CTO over many years, 20 years, with a blunt proximal cap already, and then so prior to bypass, and then you have exactly that what you explained, the great flow, and this great flow is modifying the distal cap like the very hard antegrade cap. So there's a harder fibrotic and calcified issue, and this is making the whole scenario very complex. So we find much more fibrotic issues. So when you're torquing guide wires, we often lose tips of the guide wires when you're over rotating these guide wires. So it is, I think it's nothing to start with. I really have to say that in some scenarios here, when you don't have any idea, because sometimes you even don't get some tactile feedback if you're somewhere out of the vessel or not, because this is all fibrotic, and also the pericardium is fibrotic, and also with the adventitia. So it's really not easy. Sometimes a knuckle can help you. But again, here you have to be also careful, because sometimes you push a knuckle against the resistance, and what you see, especially in REO, is that the knuckle is going also in a transversal. So you're perforating the vessel with the knuckle, because the adventitia is already gone after 20 years. Histologically, sometimes we can find this in analysis, and you push your knuckle against absolute resistance, and the side of the wall has even no resistance. What happened is that the knuckle may perforate the vessel. So this is so those kind of cases are really something I think should be done by people who are really doing a lot of CTOs.
Kambis, can I ask you the one question about regarding the collateral approach? So you use a Lima as a collateral retrograde approaches. So how often do you use a Lima in a retrograde approach in your case?
So whenever it's necessary. So my first strategy is always to try to, when I have an RCA occlusion, and Lima is giving collaterals to the posterolateral, to the PDA, okay? So my first approach is always that I try to open the native LAD antegradely. So I have to do guides, one left or right radial, for example, and I try to open antegradely, maybe rotablate this, and then go retrograde. And once I'm retrograde, I'm taking out the Lima guide and going for the RCA. But sometimes not possible, right? So if this is not possible, and I have also no epicardial collaterals from circ to the posterolateral, or if both are occluded, then I have to go for the Lima. So the Lima is sometimes a problem, right? When it's very tortuous, it may occur.
And the less backup.
And you get spasm. And if you have cases like this with really severe spasm in the Lima, but if the Lima is straightforward, a big, nice vessel, like 0, you can go very easily with a caravel, no problem, right? So it depends a little bit. Sometimes you have also to go inside and see how the Lima reacts. When you see it's getting a severe spasm, then maybe you have to say, okay, this is not worth going on and risk something on the patient.
Okay.
Kambis, can I ask you a question? I think one of the things you didn't talk about in your lecture, I realize you have limited time, is use of the occluded SVG as a potential retrograde access. And I've been quite impressed that in quite a number of cases, even bone grafts that we've known that have been included for 4 or 5 years, we've been able to use for retrograde access. And again, that may be a safer option than using the Lima in some cases. Do you want to comment on use of the occluded bone graft?
You're right, Scott. I didn't mention this point. Actually, the reason is because in my experience in the post-CABG, we have around 20% of post-CABG CTOs in our center. And the need for using the vein graft is very, very low. It's getting very low. The reason is because new wire technologies and microcatheter technologies can track nearly a very, very high percentage of all the channels to get retrograde access. But you're right. So if you're planning to do this over a vein graft, over occluded vein graft, first of all, it would be great to have an angiographic roadmap before the vein graft was open. And the limitation for using the vein graft, there's only one limitation. It may be that the insertion angle of the vein graft is unfeasible for retrograde approach. So in these kind of cases, you may go over the vein graft, may have a distal wire, and check with IVUS and knuckle down towards your anastomosis and try to do an IVUS controlled puncture. I think Nasu has done such a live case once. Yes.
Yes.
Or go to have the IVUS on the anastomosis, right, over the occluded graft, or even to dilate this and do a cart, like a cart technique. So in Scott, it is an option, definitely. And what we also didn't talk about is that people are, even when the graft is open and they're opening the native vessels, that they are going more and more in this direction, that they start to occlude the grafts. So there, I'm also not sure about it. I had some scenarios where I got acute stent thrombosis. I have seen this very rarely. And but I don't know if it's really the competitive flow or not. So I know that I think especially the Belfast people, they're occluding nowadays the grafts more and more. I know from Karen Pliotis that he's not happy with that. So he wants to have the graft patent. So there's a big controversy going on whether we should occlude the graft or not.
Controversy with no answer. Just maybe one other important thing you may want to comment on is obviously the complication of perforation and tamponade in post-bypass patient. I think that's an important learning point. Would you want to comment on that?
Definitely. Thanks, Scott. Well, what we also learned is that one perforation occurs is that in the past we understood that we always wanted to look if there is a tamponade, right? And in this kind of patients, we see almost hematoma. So what we see are free wall hematomas, especially when we work on the right coronary artery. We may see between the right atrium and the right ventricle, we may see big hematomas compressing the right ventricle, which is life-threatening. This can happen after big perforation, after stenting, but may also happen if we are going through an AC channel which have a perforation. This AC channel can compromise the right atrium. It's a very, very dangerous. So therefore, if you have some perforation after post-CABG, the way to go, in my opinion, is to fix it immediately. So put your cover stent or fix the channel with coils. So I'm not hesitating anymore with this kind of things, that because the experience learned me, sometimes there's only one tiny epicardial channel, a little bleeding, and think it might be okay. You give the patient protamine, send it up, and he might end on ECMO. This all happened to us already. So therefore, for me, there is no doubt. I want to fix the problem immediately on the table, and I'm very aggressively coiling these channels, especially in post-CABG patient.
Okay, thank you for your nice talk and nice discussions, but time is limited, and so thank you for your excellent papers and a nice rediscussion. And first of all, the ostium, second one, the double CTO and the post-bypass field, which is very important for the CTO-PCI. And next year, I hope to come join us together again. And please take care of your health. Thank you very much.
Thank you so
Thank you
much.
very much.
Thank
Thank you very much.
Bye.